guys hear us on?
Make sure.
Which link? I think so. He started it. Chris started it, so I think soon. No,
I did, yeah.
Oh, you did, right?
Yeah.
Or
Did he do that again?
Chris? Can you help us with presenter mode?
How'd you get the presenter mode here again? I'm sorry.
Oh.
How did you get presenter mode up
How'd
here?
you get presenter mode on?
No problem. If you just go, why did it exit us?
No, we exited.
Yeah, I was trying to make sure that it would.
Yep.
You good to go? All right. Good afternoon, everyone. I'm Hafsa. I'm going to be talking about chronic thromboembolic pulmonary hypertension. I wanted to thank Dr. Kelly for providing me with the resources that I used to prepare this talk. I learned a lot. I thought I knew a little bit about CTEPH, but apparently I didn't really know that much, maybe. I have no relevant financial disclosures. This is the outline of the talk. We're going to spend some time talking about definition and classification, epidemiology, pathogenesis, risk factors, clinical features, and then we'll probably spend a little bit more time talking about diagnosis and diagnostic modalities and the management strategies that we have for operable and non-operable disease. So, definition. So, chronic thromboembolic pulmonary hypertension, or CTEPH, is a progressive pulmonary vascular disease that eventually leads to pulmonary hypertension, usually resulting from incomplete resolution of prior pulmonary thromboemboli that will eventually lead to chronic fibrotic flow-limiting organized thrombi within the pulmonary vascular bed. What is the difference between chronic thromboembolic pulmonary hypertension and chronic thromboembolic pulmonary disease? I think CTED should be a talk on its own. It's a big talk on its own, but just for the sake of time, I wanted to kind of point out the major differences. It is the same disease, so chronic thromboembolic pulmonary vascular disease, with similar symptoms and similar perfusion defects, but without resting pulmonary hypertension. This is kind of just a table to show the differences between CTEPH and CTED, and the major difference is the absence of pulmonary hypertension at rest. Next, we're going to talk about classification, and we all know that CTEPH is classified as a group 4 pulmonary hypertension, but we also know about the recent World Symposium of Pulmonary Hypertension update classifying pulmonary hypertension into 2 different subgroups, precapillary and postcapillary pulmonary hypertension. So the diagnosis of pulmonary hypertension, it's not a PH talk, but just kind of a recap. The diagnosis is made when you find a mean pulmonary artery pressure of more than or equal 20 millimeters of mercury on a right heart cath. You subclassify patients into pre- and post-capillary pulmonary hypertension based on a pulmonary artery wedge pressure of less than 15 and a pulmonary vascular resistance of more than or equal 3 Wood units. And the equation for calculating the pulmonary vascular resistance is mean PA minus wedge divided by the cardiac output. Now, nationwide, there's obviously very strong evidence to suggest these thresholds, and they are adapted by the WSPH. But the implications on on CTEPH and CTED, we still don't know a lot about that, and this is probably something that will come up in the next few years. So the next slide, I really like this slide because it's kind of it shows what precapillary and how you get postcapillary and what precapillary means, so it's more. So now we'll talk about CTEPH, and determining the exact precise incidence is very complex because we think that CTEPH is often underdiagnosed. Usually data has been, shown that CTEPH originates from 1 or 2 prior episodes of PE, but occurs only in 0.6 to 4.4 patients who've had a prior PE. So there's some discordance maybe with the reports worldwide. So if we look at the reports, there's a national registry or an international CTEPH registry that looked at Europe and Canada and saw that patients who were diagnosed with CTEPH, 75% of those patients reported a prior PE. But if you look at data out of Japan, only 15 to 33% of the patients reported a prior PE. The same data from Japan showed an 80% predominance, so data is somewhat discordant between the regions. Pathogenesis, and I'm going to spend a little bit of time talking about pathogenesis. I think it's important. It's not very well understood, but there's several very strong theories for the pathogenesis of CTEPH. And we still don't really know why certain people with PE will, go on to develop CTEPH and some will not. But our theories is patients who are at risk, and we'll talk about these risk factors, will have a PE incidence, they'll develop a PE. They'll have organized thromboembolic material within the pulmonary vasculature. There will be risk factors that could influence the remodeling, and because of the patient's risk factors, if they've had risk factors for CTEPH, there will be altered remodeling. So there's endothelial dysfunction, intimal thickening, defective angiogenesis, plexiform lesion formation, and eventually impaired fibrinolysis. Eventually what will happen is you'll have increase in your pulmonary vascular pressure and your pulmonary vascular resistance, development of pulmonary hypertension, and eventually right ventricular failure. So this is kind of just another slide to talk about the pathogenesis. And like we said, so you have patients who, hopefully it's a little clearer on your screen, but you have patients who have risk factors, so there's hypercoagulability, and we'll talk about the risk factors a little bit more, but maybe they have, impaired fibrinolysis, they develop a PE, there's incomplete resolution, then an obstructive thrombus starts to organize or remodel, they develop pulmonary hypertension, RV dysfunction, and eventually, if not treated, death. A little bit more time to discuss pathogenesis. It's probably important because when we talk about risk factors, we'll also touch base about on pathogenesis. So other pathophysiologic hypotheses that exist is that patients will have defects within the fibrinolysis pathway. So it's not that they're already at risk of, not only that they're already at risk of developing thrombi, but they also are at risk of resolving these thrombi because of defects in fibrinolysis. So risk factors, and I think it's good to kind of divide this into 2 different categories, PE-related risk factors and then patient-related risk factors. So if you have someone, so let's say, we see a patient on the inpatient side and they have a PE. They're admitted in the MICU or on F2, and you're thinking, well, I want to know, is this patient going to develop CTEPH later on? Should I be watching them a little bit more, maybe sending them to the PH team? So the things that you will want to look for is RV dysfunction following a PE, if the patient's developed an unprovoked PE, if there was a diagnostic delay, and I think the reports had said about 2 weeks till presentation, if it's a large thrombus, or if the patient has had recurrent thrombi. So patients who have any or all of these are probably at higher risk of developing CTEPH and will probably require a little bit more monitoring. And then patient-related risk factors are if they have any thrombophilic disorders, if they have cancer, chronic osteomyelitis, IBD, a prior splenectomy, anything that puts them at risk of inflammation or if they're in an inflammatory state. This is just another kind of diagram to talk about the risk factors. And interestingly, I think one of the papers that talked about finding at least 20% of patients who developed CTEPH also had antiphospholipid antibody syndromes. 41% had elevated factor VIII levels. However, antithrombin 3, protein C, protein S, factor V, Leiden, there was no association between them. Now, clinical manifestations. What's that? Oh, does that change treatment and? Oh. I actually didn't read about that. I was mostly talking about, like, I was only focusing on outpatient management of chronic CTEPH. But that's a very good question. I'll actually look back and read, because we do get patients who have PE and get fibrinolysis, but Dr. Kelly has the...
So in terms of trials for thrombolytics, we have some sort of signal for that, although we just don't. Moving forward, when we look at high.
Okay, so next we're going to talk about clinical manifestations. And the clinical manifestations, and this is probably where the underdiagnosis of CTEPH kind of stems from, because it can present like any other, disease. But when we talk about clinical manifestations, I think it's important to kind of group it into features of pulmonary hypertension and then features of thromboembolic disease. So patients will usually present with maybe dyspnea, fatigue, lower extremity edema, abdominal distension, presyncopal or syncopal symptoms, and that's related to their underlying pulmonary hypertension. They could have, signs of a DVT or signs of RV failure, or they may report pleuritic chest pain because of a PE or a pulmonary infarct. And oftentimes, at least in the general population, PH will be diagnosed while looking for other causes. Say, you get a patient in clinic and they're saying, oh, I'm really short of breath and I have some lower extremity, or I'm fatigued and short of breath. You might get PFTs and find that the diffusion is low, and then maybe you'll get echo and you're looking for LV dysfunction or RV dysfunction from other causes, and then you find RV dysfunction, and then you send them for PH, and we'll obviously screen them with a VQ scan, and then the diagnosis kind of rolls down. So when to suspect CTEPH? When you have patients who have risk factors, kind of the risk factors that we talked about, patients who've had a PE and have had persistence of symptoms 3 to 6 months after the acute incident, and part of the workup for PH. So I know in our clinic, whenever we get someone who has new PH, we always screen them with VQ scan. So it's always a standard of care here. As we look through the data, it's not a standard of care in some institutes, but usually it is part of the workup for initial presentation of PH. Looking at the data from the in a European CTEPH registry, it was observed that it took a median of 14.1 months from initial clinical encounter till diagnosis of CTEPH, and it's a long time. It's more than a year, obviously. It's probably because the signs and symptoms can mimic so many other common diseases, and probably because it's very under-recognized by the general practitioners and maybe some also general pulmonologists. The data from the same registry looked at the incidence of prior PEs. It found that 74% of patients had a prior PE, but actually 56% of patients only had a prior DVT. So even when you have someone who has a DVT but not a PE, that is a risk factor, and that is something that should point to, okay, maybe I need to look into CTEPH a little bit. Now we'll talk about diagnostic modalities. And CTEPH is usually diagnosed when you have evidence of the following. So you have hemodynamic values of pulmonary hypertension on a right heart catheter. You have a mismatched perfusion defect on a VQ scan. We'll talk about why VQ scan is the first diagnostic modality. And then you have indicators of CTEPH on advanced imaging techniques. And this slide, I like this slide because it's kind of like how you would probably come about the diagnosis, maybe a little bit differently in clinical practice, because you will get a VQ scan while you are also waiting on a right heart cath at the time, and immediately once you see that the patient has an elevated pulmonary artery pressure on an echo, so before the diagnosis of PH on a right heart cath. And then once you get a VQ scan, you'll probably need more advanced imaging techniques. So this is a diagram just to show the importance of the VQ scan. VQ scan is an excellent disease screener. So it can screen patients as an excellent negative predictive value. Usually, if a VQ scan is negative, CTEPH can be excluded. Pretty strong certainty. Talking a little bit more about VQ scan, is, like we said, it's the initial screening test. It has a very high sensitivity, 96 to 97%, and a very high negative predictive value, almost 100%. And that's why it's a strong recommendation to start with a VQ scan per the European Society of Cardiology and European Respiratory. Despite that, when looking at the Pulmonary Arterial Hypertension Quality Enhancement Research Initiative Registry, Pulmonary Arterial Hypertension Quality Enhancement Research Initiative, the data actually showed that only 57% of patients with PAH, diagnosed PAH, have had a prior VQ scan. So why is it that we are not doing more VQ scans? It's probably because the disease also has low specificity, meaning that it can be positive when you have other vascular lesions that could mimic, CTEPH. So let's say you have vascular sarcomas or PVOD, then you may have the same perfusion defect on a VQ scan, and you'll ultimately, even if you find a positive VQ scan, ultimately you will still need more advanced diagnostic imaging modalities. CT pulmonary angio. So CT pulmonary angio is an excellent test. It can evaluate underlying abnormalities. It can locate the abnormality and also describe the nature of the abnormality. It can also assess concurring parenchymal and mediastinal lesions. It identifies other pulmonary vascular abnormalities that could look like CTEPH on VQ scan but are different, things like vascular sarcomas, PVOD, or fibrosing mediastinitis. How good is CT pulmonary? Oh, sorry, we're not yet at how good it is. But what would you find when you do a CT pulmonary angio? You'd be looking for recanalized or organized thromboembolic material within the pulmonary arteries, bronchial arterial collateral flow, and then mosaic perfusion or mosaic attenuation of the parenchyma. So the left side, most of the screen, you see that there is an acute PE right here. And then this is the right descending pulmonary artery. Can you see my, okay. There's an acute PE, and then there is, if I see it there, I can't see it here. There's vascular distortion here, and web formation, intimal thickening, and then eventually there is collateral blood flow or distal blood flow. Another slide and kind of showing, and then there is, web formation and something. And then this is showing mosaic perfusion, which can also be present in interstitial lung disease, but it's specifically called mosaic perfusion because it's related to a perfusion defect, or mosaic attenuation, but mosaic. So how good is CTPA? For main or lobar disease, it's really good. It has a sensitivity of about 89 to 100%, specificity of 95 to 100%. For segmental disease, it is less sensitive and specific, about 84%. Sensitivity and 92% specificity. Now, potential difficulties would be also interpretive expertise. So you probably will need, thoracic radiologist who has expert tests. And like we said, for segmental and subsegmental, usually it's not as good as picking up lobar or larger vessel. There's other techniques out there, so other advanced CT techniques, dual energy CT or DECT, EKG-gated area detector CT. Do we have any of those here? I don't, we do? Yeah. Yep. And, you know, these are emerging, and there's not a lot of data to show how sensitive or how specific they are compared to the gold standard, which we'll talk about. But some data about CBCT and ADCT, there's one study about CBCT, and they saw that comparing CBCT to pulmonary angio, the pulmonary actual angio, they were able to pick up all the segmental disease, but only 69% of the subsegmental disease. They are used also when you are doing percutaneous intervention to better localize the smaller vessel disease. MRI is available. It doesn't have radiation. It can evaluate the parenchyma also, and it can evaluate the underlying right ventricle, but unfortunately, it requires also expert interpretation. It's pretty time-consuming, not readily available, so that's why it's not as popular. And now talking about the gold standard. So the gold standard is pulmonary angiography, and that's what we usually do when we suspect CTEPH while we're doing the right heart cath. And when it's combined with right heart cath, it can confirm CTEPH to a subsegmental level of disease. It's good because it can localize the lesion and also determine if this is a surgically feasible procedure or not. What will you look for when you do pulmonary angiography? You're looking for webs or bands. You're looking for intimal irregularities. You're looking for pouch defects, abrupt narrowing, or complete obstruction. And there's actually a classification system for pulmonary angiography. So A on the screen is ring-length stenosis. B is a web lesion. C is subtotal occlusion. D is total occlusion. And then E is a tortuous vessel. This is, I think, more probably important for the surgeon who's going to be performing the procedure or for the interventional cardiologist in case the patient is going for a percutaneous procedure. These are just other findings that you can see there. So in A, there's narrowing. B, there's contrast, so there's a pouch defect, so early contrast. And then in C, there's a web defect. And it's important to get multiple views because sometimes the lateral view will be giving you the better view of the narrowing or the complete occlusion. Now we'll talk about management. How are we doing on? So it's important to classify diseases into two entities, operable versus non-operable disease. And I like this slide a lot because it kind of tells you, based on where the involvement of the disease is, what your management plan will be. So the bigger the lesion or the bigger the vessel that's involved, so main and lobar, probably going to be referring them for surgery. But as you start to get into your segmental, subsegmental, and definitely with your microvasculature, you're probably going to be looking at less invasive procedures than maybe medical management. And it makes sense, you know, you won't be able to access those lesions because they're probably very distal. Now, this is a slide just to emphasize on how important it is to refer patients with CTEPH to CTEPH excellence centers, because the decision to operate or not operate or do anything else is really a multidisciplinary decision. It's part of usually a team where there's a CTF surgeon, an interventional cardiologist, a pulmonary vascular specialist, a radiologist, and there's I think the biggest center here is UC San Diego. Most of the data that we have is published from them too. So indications for surgery or pulmonary thromboendarterectomy. When you have someone who has a mean PA of more than 30, a PVR of more than 300, a NIHA class 3 to 4, or even symptomatic CTED who develop pulmonary hypertension with exercise. So that's also an indication for referral for assessment. And when you assess someone whether they're going to be operable or not, you're going to be looking at 3 different factors. So disease-related factors, patient-related factors, and then hemodynamic-related factors. So disease-related factors, you know, it makes sense. You know, how accessible is the lesion? Technically, can we perform this surgery or not? Patient-related factors, is the patient a good candidate for surgery? Do they have any other contraindications for surgery? What's their age? What's the general health of the patient? And then hemodynamic-related factors, and we'll talk about that a little bit more, but it's important to, assess the patient's hemodynamics on a right heart cath before proceeding with surgery. One of the most important factors is the pre-op PVR, because an increased PVR more than 1,000 to 1,200 correlates with an increased risk of post-op mortality, and this was a deep question also. So patients who have high PVR likely have higher mortality, but also will likely benefit more from the procedure because they have the highest improvement in their PVR after surgery. It's not necessarily a contraindication. This is something that should be looked at very specifically within the multidisciplinary team. Having a high PVR and also low level of surgically accessible lesions may mean that the patient probably has more microvascular disease. Again, this is not a contraindication for surgery, but just to say that the patient should probably be discussed in multidisciplinary team at length. Now, also important to mention which patient is inoperable versus not a candidate. So when you have someone who is technically inoperable, meaning that I, as a multidisciplinary team in a CTEPH Excellence Center, has looked at this patient and said, we don't think that we can do this, we can't access this lesion. In that case, you should refer a patient to other centers. There's very few centers that perform this surgery. Some have developed expertise in different types of lesions, and if you personally don't think that you would be able to, as a team, perform it, then there may be other surgical centers that would be able to perform it, as opposed to someone who's not has an accessible lesion, but probably is not a candidate because of other reasons. And that's when you would probably look for different medical management strategies or even percutaneous management. So this is the UC San Diego surgical classification for the lesion. So level 0 is when there's no evidence of thromboembolic disease in either lung. Level 1 is when there's CTE starting in the main pulmonary artery. Level 2 is when it's at the lobar arteries or the main descending pulmonary arteries. Level 3 is where it's segmental arteries, and level 4 is where it's subsegmental arteries. Pulmonary Thromboendarterectomy, it is endorsed by the American and European guidelines in all suitable patients with accessible lesions. So if the patient can get surgery, they should get surgery. It offers the best chance of survival and long-term outcomes. It was first introduced in 1970s by UC San Diego, and the techniques have improved a lot since then, resulting in improvements in outcomes. So right now, actually, mortality rate is only 2%. That's a reduction from 20% when it was first introduced. I want to show a video real quickly. Very short video. How do I share this? Drag what exactly? Oh, God. This? I'm gonna mess up the whole thing. Sorry, guys. I'm not very
You got it. Just move it up, right?
Okay. See, it's not that hard. So this is just, I thought it was interesting. And I wanted to talk a little bit more about it because I think that, as pulmonologists will probably be explaining to patients in brief what the procedure could mean. Satisfying, I thought. Yeah, yes. So the patient's actually placed on a bypass. Do I just back to? Please. Or any of the ladies.
You just want to go back to the presentation.
Go back. So, how's the procedure performed? So I'll try and go over this as fast as I can, but I think it's very impressive. So start with a median sternotomy, cardiopulmonary bypass, very deep hypothermia, and total circulatory arrest. The deep hypothermia can take up to 70 minutes. Usually the patient is cooled down to 18 to 20 degrees. Heart and the head are wrapped with special cooling blankets and jackets, so it's an extensive procedure. Usually between 30 to 75 minutes, depending on the body habitus, in order to cool the patient to the temperature that's desired. Clamping of the aorta, cardioplegia, and then the main PA is explored from between the superior vena cava and the aorta, and then they start to dissect identify if there's any lesions, and extract these lesions. It's an extensive procedure. These are just some of the lesions that have been moved in the test based on the surgical level. All right, so let's do a question. This is a C question. So you have a 39-year-old woman with SLE and antiphospholipid syndrome. She's on warfarin. She's coming in for shortness of breath, lower extremity edema. She has some JV distension at all the way to the angle of the mandible. She's got a parasternal heave, an accentuated P2 component of S2, tricuspid regurg murmurs. You get an echo, it shows marked RV enlargement and hypertrophy, depressed right ventricular systolic function. There's dilation of the inferior vena cava. She's probably an RV failure, basically. Pulmonary artery systolic pressure is 100. This kind of looks like something that we would get, in all honesty. Like, we get a lot of, I feel like, RV failures. So you do CT pulmonary angiography, and you have extensive proximal organized embolic material with partial and complete filling defects. You have a mural defect along the walls of the right and left interlobar pulmonary arteries. There's areas of incomplete recanalization resulting in intramural webs. This is how her CT looks like. This is her VQ scan. She's a right heart cath. Her mean PA is 57, so it's not as bad as the echo. Her wedge is 13, her index is 2.3, and her pulmonary vascular resistance is 782. So then she goes for you obviously say she probably needs to get surgery, so you send her to a CTEPH Excellence Center, and she gets the surgery. She has improvements in her post-op hemodynamics, but then on day 1, she starts to have increased oxygen requirements. And then, the chest X-ray was not there. So I must have deleted that by mistake when I was doing a little bit of housekeeping on it. But her chest X-ray, she had some pulmonary edema. Which of the following is correct for the patient's perioperative complication? Perioperative methylprednisolone reduces its incidence. Its incidence is higher in patients with significantly elevated preoperative right atrial pressure and total pulmonary resistance. Preoperative use of inhaled nitric oxide reduces the incidence of this complication. Preoperative use of low tidal volume ventilation strategy reduces the incidence of this complication. What do you guys think she had? So she had, she had CTEPH, she had surgery, and then post-surgery she decompensated. Reperfusion injury, yep. So what's the answer? Well, you guys tricked me. I almost went to the answers. I thought that was the question. Anyone? Any takers? B? All right. Yeah, it's correct. It's incidence is higher in patients who have higher right atrial pressure and pulmonary resistance. The reperfusion injury happens in 30% of patients within 48 hours of PTE surgery. Usually, what's the mechanism or the pathophysiology is it's a high permeability edema resulting in hypoxia and new radiographic opacities in the areas of the lungs that have been reperfused. I think that's why it might have gotten a little harder because the X-ray, for some reason, I must have deleted that by mistake, but the X-ray was basically in the areas that she had treatment, she had pulmonary edema. And it can range from just mild post-op hypoxia to acute hemorrhagic pulmonary edema, and sometimes patients actually have to be placed on ECMO. Do we give them steroids? No, it doesn't. Data has not shown any improvement with steroids. The outcomes depend on several factors. It depends on how chronic their disease is, the expertise of the team that's done the surgery, pre-op pulmonary vascular resistance, the exercise capacity, functional status, comorbidities, and distribution of the disease. So just as a segue to talk about complications. So how safe is it? We've talked about the fact that it's, post-op mortality rates less than 2% now at UC San Diego. Some of the complications that can happen are, inherent to the fact that this is a cardiopulmonary procedure, so it can lead to arrhythmias, effusions, pericardial and pleural effusions. It can lead to atelectasis, wound infections, and delirium. Reperfusion injury, the data out there suggests about 9.6%. Steroids have no role in the management of reperfusion injury, so they're not actually given pre-op or post-op. Outcomes, 5-year survival rate for UC San Diego is 82% and 10-year survival rate is 75%. Their in-hospital mortality rate is 2.2. Other institutes have similar rates, about 5-year survival 75 to 90%, 10-year survival of 72%. Patients have the procedure obviously shows significant improvements in hemodynamics, functional status, RV function, and LV function, and survival compared to patients who don't engross. Now, I'm going to talk about non-operable disease, which I think actually maybe plays a role in what we're going to do more. And when we're talking about non-operable disease, we'll talk about medical management and percutaneous intervention, which is BPA. So medical management, we'll talk about, can someone pronounce this for me? Thank you, Risagla. I feel like one thing that I never learned how to pronounce it. So it's the only therapy that's approved for inoperable CTEPH in patients with in patients who've had PTE and have had persistent or recurrent pulmonary hypertension, and that's based on the CHEST-1 trial. It was a 16-week multi-center randomized controlled double-blind placebo-controlled trial, enrolled 261 patients. In the intervention, they got the medication Risagla, and then in the control group obviously got placebo. So so what did they find? Let me go. So they found improvement in the 6-minute walk, 39 meters versus a decrease of 6 meters in the placebo control group. The intervention group also has a decrease in their PVR, a reduction in the BNP level, and improvement in the WHO functional classification. And then they did the CHEST-2, which was a long-term extension study and looked at patients who had CTEPH and were on it, and they actually improved. They saw that those improvements persisted even a year, up to a year after the treatment. Then we have macitentan, and macitentan has been studied in the MERIT trial, which was a phase 2 randomized placebo-controlled trial. MERIT 1. MERIT 1 stands for macitentan for the treatment of inoperable chronic thromboembolic pulmonary hypertension. It's an endothelin receptor antagonist. They had a total of 80 patients who had inoperable CTEPH. In the intervention group, they saw that there was a 73% reduction in the PVR, whereas the PVR only reduced to 87% from baseline in the placebo control. So there's a higher reduction in PVR in the intervention group as opposed to the placebo group. At 24 weeks, they also showed improvement of 6-minute walk, so increased by 35 meters compared to only 1 meter in the placebo control. And important distinction between this one and the CHEST trial was this was a smaller study and only included inoperable patients. The CHEST trial included patients who developed recurrent pulmonary hypertension or recurrent symptoms after PTE. They also used other therapies in this trial, so 61% of the patients were also using an inhaled prostacyclin or other forms of therapy. Bosentan, the benefit trial, which is Bosentan effect in inoperable forms of chronic thromboembolic pulmonary hypertension. It was a double-blind, placebo-controlled, randomized controlled trial that looked at inoperable or persistent or recurrent pulmonary hypertension after PTE and showed a 24% reduction in PVR in the Bosentan group compared to placebo, but there was no difference in the 6-minute walk, which was a primary outcome. The two primary outcomes were hemodynamics, or the PVR, and the 6-minute walk. For the sake of time, I'll go a little bit faster, but this is kind of just a diagram to show all the different trials. Sildenafil, there was one study that was very small and had 19 patients with inoperable CTEPH. It was a double-blind placebo-controlled pilot study. Primary outcomes were 6-minute walk. Secondary outcomes were WHO classification, hemodynamics, quality of life score, and BNP levels. They did show improvement in the WHO class in pulmonary vascular resistance, but there was no improvement in the 6-minute walk. They reassessed the patients. Out of the 19, they were able to reassess 17 of them a year after the study, and they actually showed improvement at that time in the 6-minute walk distance, activity, and symptom components of quality of life, cardiac index, PVR, and BNP. This study was eventually thought to be not powered enough to test the primary endpoints, but it did suggest beneficial effects in favor of sildenafil. Epoprostenol, there's just been retrospective studies. One of the retrospective studies looked at 27 patients with inoperable CTEPH with a NIHA class of 3 or 4 that got IV epoprostenol, and it showed improvement in 6-minute walk, PVR, and mean pulmonary artery pressure at 3 months. So the 6-minute walk at baseline was 265 meters, and after treatment improved by 66 meters, and that was at 3 months. The NIHA functional class improved by 1 class in 11 of the 23 patients, and the mean pulmonary artery decreased from a median of 56 to 51. Epoprostenol, there was one single-center prospective uncontrolled observational cohort study that included patients who had inoperable CTEPH with a WHO class 3 to 4 6-minute walk of less than 380 and at least 1 admission for RV failure within 6 months. They actually went through strict guidelines on how to define RV failure. This study excluded ILD patients who had a total lung capacity of less than 60% or an FEV1 FVC ratio of less than 50%. They had about 28 patients enrolled over a period of 6 years, and they had 31 historically matched patients. They showed improvement in 6-minute walks, WHO class, BNP levels, PVR, and hemodynamics, and they actually showed that there was improved survival, 56% in patients who received treprostinil as opposed to 16% at 5 years. And the match between the 31 historical patients and the 28 patients who were enrolled was based on 6-minute walk, WHO class, and hemodynamics. Percutaneous therapy or balloon pulmonary angioplasty or BPA. How it works is basically by disrupting organized flow limiting obstructions. It causes significant, in order for it to cause significant improvement, you need to revascularize multiple lesions, but it is part of the recommendations for ESC and ERS guidelines in patients who cannot get surgery or have unfavorable risk-benefit ratio for surgery. It can be performed if you have symptomatic CTEPH and you can't get surgery, or if you have CTEPH that's recurrent or persistent after surgery. It can also be performed as a rescue therapy in rapidly deteriorating patients prior to surgery in order to bridge them and stabilize them. And it can also be combined in certain centers. So in certain centers, maybe they'll be able to do the surgery on one side and then maybe do BPA on the other side in lesions that are not as easily accessible. Complications, depending on the center and the expertise of the center, mortality rate ranges from 0 to 1%. Higher mortality rate if it was, higher rate of reperfusion injury if it was a first procedure, if the patient has baseline severe pulmonary hypertension or a higher BNP. Pulmonary vascular injury can occur, so vessel perforation and rupture has been described to occur up to 7%. So what are some of the short-term outcomes? Improved 6-minute walk to distance, WHO functional class, hemodynamics, pulmonary perfusion. PH will not immediately, the pulmonary hypertension will not immediately resolve. It takes weeks for it to resolve. And studies out there, have shown improvement in quality of life, symptom resolution that's disproportionate of the degree of improvement in main pulmonary artery. So we think that there might be other effects for the procedure that result in improvement that are independent of improvement of the pulmonary artery pressure. UC San Diego does this procedure, and they've actually shown pretty good outcomes. So they did a total of 183 procedures and on a total of 38 patients. They showed 0% major complications. They've had minor complications up to 6.6 minor hemoptysis. 1-year follow-up, they've shown improvement in, like we said, WHO functional class, 26% reduction in the mean pulmonary artery pressure, and 90% survival, with both deaths in the patients that they've had not being related to the procedure. Literature also describes improvement in RV function over time with remodeling and improvement in renal function, which makes. Last slide is anticoagulation. Almost didn't put this in because I was like, you're going to anticoagulate them, but all CTEPH patients should receive lifelong anticoagulation. Antiplatelets are not a suitable alternative. There's no data to support one anticoagulant over the other, so anything that the patients can tolerate So in summary, CTEPH is often an underdiagnosed disease. Management is evolving, but we've had remarkable improvements over the past years with improvements with new techniques and surgeries that we'd be able to offer for patients. And that's why CTEPH patients should be referred to a CTEPH Excellence Center for multidisciplinary. Questions? I think that the one study that's been or the one drug that's been approved is the rosuvastatin. Practice before I sleep today, how to say it. Rosuvastatin. That's the only medication that's been approved, but all the data otherwise has shown improvement with treprostinil, epoprostenol. I don't know what.
It's complicated, so it was an excellent review. The piece that I think is the clot that gets chronic and endothelial. All of the rest of the vessels are swelling that happens in all vessels. The rest of the lungs are high capacity. That's why really, however we treat it, UCSD do everything. On Abdulla, on PO, on inhaled, on oral, nothing. So,
Yeah, do we do them?
what our group,
From what I.
so, for a long time, we weren't doing it at all. Really just for our CTEPH patients, fine. I haven't sent anyone.
That's interventional cardiology. That's what the literature.
I have the multidisciplinary.
It is scary, it's perfected in children for. Really only know.
Yep.
Perfected in back to this country.
Yeah, it went out of favor for a long time until I think the last 5 or 7 years.
The truth is, are unidentified. Always have to have. You notice when she gave you the minutes, you have and hypercoagulable risk factors. They're all inflammatory. Becomes really keeping in mind. Thank you.
Thank you.
It doesn't feel like great job.
Oh, thank you. Thank you for being here to answer.
Oh, no, of course.
Great. Good.